We're almost out of time. We just had one area I wanted to touch on before we finished up, and that was on a safety question that I think has been hung over the head of VEGF tyrosine kinase inhibitors for a long time, and that is cardiac risk. Clearly, these patients that we're treating today with metastatic renal cell carcinoma are at high risk of dying of renal cell carcinoma in the next few years. But we don't want to have a premature death because of toxicity. And I think it's one of the concerns out there that could be related to these agents because of the on-target biology of inhibiting VEGF. There are some recent studies that have looked at now some larger safety profiles and cohorts around cardiac toxicity. Brian, do you want to comment a little bit on what we know and maybe what we don't know, and sort of what are sort of the management recommendations around cardiac issues?
Sure. Last year at ASCO, Naomi Haas presented data from one of the adjuvant studies, which was an ECOG study of sunitinib versus sorafenib versus placebo, and they looked at a cardiac sub-study, which was, I believe, mandated by the NCI, who helped fund the study through the cooperative group, and reported really a very low incidence of cardiac toxicity. Patients got echoes at regular intervals, et cetera. Now, the caveats to that study are that, as Bob mentioned, tolerance of these drugs in the adjuvant setting, for whatever reason, seems to be less than in the metastatic setting. So it wasn't really reported, but the average duration of therapy is probably not the whole year of intended therapy, but probably half that or somewhere around there. So different than the metastatic setting, where we have patients on that, an average of 10 to 12 months in the frontline setting. But I think it underscores the point that I think in general these drugs certainly have cardiac side effects. You need to be aware of specific patient circumstances, patients with a history of CHF, ventricular arrhythmia, what have you. I don't do routine cardiac monitoring in terms of EKGs or echoes. I think probably what I do most routinely is blood pressure monitoring. So all my patients buy a cuff, measured at home every day, bring me the numbers when they come in, and that allows sort of early and aggressive management of hypertension, which obviously is a step towards preventing those cardiac side effects. So that is one piece of data, again, relatively limited because of the trial population in which it was done, but it provides some reassurance that these drugs can be given without large-scale cardiac effects.
Yeah, and Brian, as you know, a few years back, we pulled the data available from the sunitinib database across several phase 2 trials and the phase 3 trial, and we looked specifically at the ability of sunitinib to cause kind of cumulative cardiac toxicity in patients that were on long periods of time, some of these patients 2 to 3 years, and we did not see any excess cardiac toxicity with the length of time they were on therapy. So that speaks to a little bit more to the safety, that it is there, a low level. You need to be careful, monitor for it, and the appropriate patient.
Okay, great. Well, we're just about out of time, and I'd like to summarize. I'd like to give each of the speakers a chance to maybe make their kind of final comments about the issues we've talked about, the frontline treatments, the data around those frontline options, the second-line treatment choices that we have, the data that's based there, the emerging therapies that we see coming, the limitations from our trial designs that we have today in interpreting this data, and how we think about managing our patients, and ultimately, how we're going to move some of these therapies up into the adjuvant setting. I think we've covered a lot of information. Bob, do you have any comments on that?
I think, first of all, this has been a great session, and thank you for the kind invitation. I think that our education in kidney cancer continues to evolve. It evolves from the practicing physician to the investigators around this table. And what we all have to understand and recognize is that it continues to be very dynamic. That it almost seems that every year, ASCO 2013 going forward, we're learning more, we're having to integrate more, we have to understand more, and to Eric's point, we have to think about novel ways of asking and answering questions. I think for the practicing physician, information is providing clarity, and I hope we've been able to do that through this kind of a meeting. I think one area that we haven't touched on is the evolving area of vaccines in kidney cancer. Vaccines like the Immatics product or the Argos product. Kidney cancer continues to be a hotbed of asking and answering questions that are hypothesis generating by skilled investigators and patients and institutions that are willing to participate. And it's for a person that's been in the field for a long time, it is really encouraging to see that the excitement still exists, and that we continue to seek the quest of having to find cures for this disease.
Eric?
Yeah, so I think it's an exciting time, and the last 7 years have been really exciting from a drug development perspective. Probably the most important thing for the practitioner really is to know the agents that are out there, know their shortcomings, know how to use them, and communicate with the patients so that these agents, which are good, which I think are clearly improving progression-free survival and overall survival, are given in a way that the patient can tolerate them, have a good quality of life, and enjoy that prolongation of quantity of life that these drugs can give. Clearly, we've moved from having no TKIs to TKIs. The next 5 to 10 years are going to be probably an era of incorporating and learning how to incorporate novel immunotherapies. And how that happens and how we best do that, I think it's really incumbent on us to make sure that that's done in a way that we can really help the patients the most.
Fantastic. Brian?
Yeah, I guess I would say, to echo what some of the others have said, understanding the drugs that are out there, getting a drug or drug that you're comfortable with, you know how to give, you know how to modify the dose or schedule, how to manage toxicities, how to get the most out of that drug and not stop prematurely is more important than whether you pick drug A or B. It really is. And to give a drug and give it well, I think it gives patients the best benefit-risk balance. To me, some of the recent data supports what's been my practice of VEGF, sequential VEGF therapy. I think that's becoming clearer as we get new data sets. And I think the PD-1 pathway inhibitors are really exciting, and we get to sort of hopefully, generate and lift that tail of the curve so that we're really helping more patients long term. And then we can look back on targeted therapy and say, gee, wasn't that silly that we were just extending progression-free survival by a few months? I think we're a ways from that, but at least looking forward, I'm hopeful.
Yeah. Well, it's clear to me that the rapid development of new drugs over the past several years has outpaced our ability to understand how to utilize them appropriately. And so what I'm excited about two things. The one is all the new avenues and the new targets. I think that is where the hope and future is of the disease. I'm also excited that we're having a little bit of a slowdown, if you will, a plateau that's happening that will allow us to really focus on the drugs we do have and optimize their use, whether that be looking at therapeutic drug monitoring, doing another way besides toxicity as managing how you raise the dose or lower the dose, optimizing the drug delivery, whether it be changing the schedule, et cetera. I think we have things we can do to improve the therapy we have right now as we are searching for the new classes of drugs.
Well, fantastic. And I'll just say as a monitor, it's been a real privilege to help lead us through the discussion that we've had today. I think thank each of you for your thoughtful comments on a number of these subjects. And for our audience, I'd like to thank you as well for watching this peer exchange.